described in pH 2.4 and pH 1.12. pH 2.4 is to demonstrate the correct method of calculation of drug dosage in patients, including those used in special situations. And pH 1.12 is calculate the dosage of drugs using appropriate formulae for an individual patient, including children, elderly, and patients with renal dysfunction. To partly fulfill the requirements, I have prepared this presentation on dose calculations of IV iron therapy using iron sucrose preparation. In two situations, one is where patient has iron intolerance and malabsorption, and the second is the third trimester pregnancy with moderately severe anemia. The area covered is core competency level is student should show how he is calculating, and the domain covered is knowledge and skill. A specific objective of this is that the learner should be able to calculate dose of given drug for patients suffering from a disease and under special situations. These two exercises are planned, and the teaching method will be followed is small group discussion and then performance on a skill station. Approximate time required is 2 hours, and evaluation will be done by direct observation and structured by. Now, case scenario 1. A middle-aged 65 kg male complained of weakness for over a month and passing blood-stained stool with pain during defecation. He was referred to gastroenterologist by the primary care physician for evaluation. The consultant, after physical examination, ordered investigations which revealed low hemoglobin 6 gram%, low PCV, low MCH, MCHC, and MCV. Platelets were normal and total leukocyte count was normal. Serum iron was low, ferritin was also low, iron binding capacity increased, and transferrin saturation decreased. There was elevation of C-reactive protein. Rectosigmoidoscopy was also done, and multiple ulcerations were seen extending up to descending colon. It was sent for biopsy, and histopathology examination confirmed ulcerative colitis. He was given mesalamine orally and ferrous sulfate tablets for 15 days. He could not tolerate oral iron due to gastric upset, nausea, and aggravation of diarrhea. The consultant decided for parenteral iron therapy. Iron sucrose was chosen to be infused. Now our job is to calculate the dose of iron sucrose required for him, and second is to prepare instructions for the nurse to dilute the drug in suitable IV fluid and rate at which infusion is to be given. Here, a student will perform the role of nurse, and he himself or herself will prepare the solution and administer in simulated condition. The calculation of dose of iron here. Genzoni formula is used, which reveals total iron deficit is equal to body weight multiplied by target hemoglobin minus actual hemoglobin, and then multiplied by a factor of 2.4 plus replenishment of the depleted iron stores. Now factor 2.4 comes from multiplication of hemoglobin iron percentage, blood volume, and 10,000 as a conversion factor from gram deciliter to milligram per liter, and this factor comes to 2.4. So using these parameters, the total iron deficiency in this case is 1404, approximately 500 milligrams, plus 500 milligrams is to be given to replete the depleted stores. Some advise giving 10 mg per kg to a maximum of 1000 mg. We will assume that we are taking 500 mg, so the total dose requirement is 1904 mg rounded to 2000 mg. 5 ml ampule of iron sucrose contains 100 milligram, so the solution strength is 20 milligram per ml. When 200 milligram is diluted in 200 ml of normal saline, the final dilution becomes 1 milligram per ml, and which is to be given in 30 to 60 minutes at a rate of about 3 ml per minute. Alternately, 200 milligram can also be diluted in 100 ml normal saline, which can be given in at least 30 minutes to 60 minutes. And here the rate will be 1.5 ml per minute. Now this therapy can be given 2 to 3 times weekly till total amount is administered. In this case, 2000 milligram will be administered in 10 sittings. In some protocols, upper dose limit is fixed at 1000 milligram. So we can follow that also. The exact procedure for administration will address to competency of IV administration of drug in simulated condition, and a student must know the details. The material required is 5 ml disposable syringe, intravenous set and cannula, 100 ml bottles of the normal saline, antiseptic swabs, adhesives, gloves, and the stent. Method is explain patient about the procedure in details. This is important. Take pulse rate, blood pressure, respiratory rate and temperature and record it with time. Use gloves. Open IV set and inspect for any defect. Insert the IV set spike into 100 ml bottle and half fill the drip chamber by tilting the bottle. Raise the bottle again and fill the IV tubing with saline by gradually opening the roller clamp. Ensure that air bubbles are not there. Once the entire tubing is filled, close the clamp. Fill iron sucrose in 5 ml syringe from ampule and inject into the rubber injector port of the IV set or injection port of the bottle so that drug goes into the bottle. Mix well by moving bottle upside down. Once settled, observe for insoluble particulate matter. Ask patient to lie down comfortably. Apply a tourniquet over arm to ensure filling of distal veins. Now select a suitable superficial vein over forearm and clean the skin by antiseptic or spirit swab. Hold the needle base, attach to IV set and with sharp tip at the angle of 30 to 45 degree and puncture skin to insert needle into vein. When the needle is into vein, you will see blood coming back into IV line. Insert further and secure it with adhesive. Applying adhesive is an art which is learned by practice and therefore this should be done repeatedly. Remove tourniquet. Open roller clamp and see that there is free flow and no swelling appears around the vein. This is to ensure that extravasation does not occur and patient does not complain of any pain. Once there is no pain, then one can run the solution at a rate of about 10 to 20 drops per minute for 5 to 10 minutes to observe any untoward reactions. Once 25 ml is run without reaction, then entire volume is delivered in 30 to 60 minutes. Once IV administration is complete, close the clamp and remove the adhesive over vein. Remove needle in the same direction and press the puncture site by a swab. Ask patient to flex forearm for about 2 to 5 minutes to ensure sealing of the puncture site. Measure pulse rate, blood pressure, respiratory rate and temperature and observe further for at least 30 minutes before discharge. Instruct patient to visit hospital 2 days later for IV administration of next. Certain precautions must be observed. Test dose should not exceed 10 to 25 ml in 15 minutes and we must carefully observe the signs and symptoms of adverse reactions. Avoid extravasation as solution is highly alkaline, will cause thrombophlebitis. The diluent used is normal saline and not 5% dextrose. Dextrose is acidic, therefore reaction would occur. Do not give oral iron simultaneously because oral therapy will interfere with the assimilation of iron and therefore it should be started only after 5 days of the last injection. Freshly prepared solution should be used and that means Dilution must be done at the time of administration. Now, how do we monitor the effect of therapy? Expected rise in hemoglobin would be 1.5 gram per week, and earliest changes occur with rise in reticulocyte count. A good response means at least 3 to 4 times rise in reticulocyte count within 10 days. Now, case scenario 2. This is a case of 7-month pregnant woman from a village who attended district healthcare hospital center for weakness, lassitude and inability to carry out routine work. On examination, gynecologist found pallor, nails were flat and tongue was bald. She had attended antenatal clinic there in her village, and record shows body weight at the time of first visit was 56 kg. The gynecologist advised blood test because the preventive oral therapy at ANC was not effective, and the test relieved 7 gram hemoglobin, low PCV, low MCH, low MCHC, low MCV, low serum ferritin and low transferrin saturation, and higher iron binding capacity. Transferrin saturation was just low than normal. Parenteral iron therapy with iron sucrose was planned in view of 7 months pregnancy because only 2 months were left for delivery and rural. Calculation of parenteral iron in this case would be same formula will be used, but the body weight used will be pre-pregnancy body weight. So the iron calculation comes to about 1500 milligram, which includes 560 milligram for stores. In some protocols, the upper limit is 1000 milligram, so we can use either 1500 milligram or 1000. Administration, dilution and procedure, method of dilution, procedure and administration will be exactly same as I have discussed earlier in case 1. Therefore, all the precautions, all the steps will be followed. Parenteral iron therapy is usually well tolerated and no untoward reactions occur. Headache, vomiting, nausea, dizziness, joint pains, paresthesia, sometimes muscle pain may occur. Serious adverse effects include hypotension and cardiovascular collapse, and these are actually very rare when dose is fixed at 100 mg per day. They may appear if it is infused in higher dose or at a rate which is very slow or very fast. Therefore, we must use 100 ml of the solution in 30 minutes. One must watch for uneasiness, chest pain or constriction of chest and nausea, vomiting, tachycardia throughout the infusion period, and rarely severe allergic reaction as noted as hypotension may occur, and usually its occurrence is 3.3 cases per million per year. In order to meet with the emergency, one must be ready with an emergency tray at hand, adrenaline, mask, oxygen, and a doctor should monitor the therapy. Now in the last I will discuss indications of intravenous iron sucrose therapy in pregnancy, and that will be applicable to all iron pregnancy. Intolerance to oral iron, poor compliance to oral iron when 6, 2 or 4 tablets cannot be done taken by the patient. At least 200 mg elemental iron should be given, of which 50 mg will be elemental iron absorbed. Only then there will be adequate response. Often it is difficult to take 200 mg daily. Inadequate absorption due to gastrointestinal disorder, malabsorption, chlorhydria. In our case, ulcerative colitis was a concomitant disease that resulted in poor oral tolerance. Lack of response to oral iron is also another one. That means if adequate reticulocyte count doesn't occur in 1 to 2 weeks, then probably iron is failing. Then pregnant women with severe iron deficiency anemia presenting late in the pregnancy, as is our case. In this case, we have to give parenteral iron so that the complications of anemia in pregnancy do not occur. So finally, postpartum anemia can also be treated by intravenous iron. How do we evaluate the performance of a student? Overall assessment will be done by direct observation at a skill station. 2 structured viva cards are prepared and pre-tested. Card 1 have limited number of questions, 4 questions. Enumerate 3 common parenteral iron preparation. Can we give entire dose of iron sucrose in one sitting? Third question is, if a patient requires IV iron, request for single IV dose. Can we give iron sucrose? And fourth is, what will you do if patient develops allergic reaction? What are the indications of parenteral iron therapy? Enumerate 2 parenteral iron preparations given IV. Will you advise concurrent oral iron therapy along with parenteral iron therapy? How will you assess the response to parenteral iron? What is the earliest indicator of recovery? Now with this evaluation, I am sure that the students will be benefited. They will also develop skill and ability to be able to calculate the intravenous iron dose and administer in special situations as seen in our skill competencies of the CBME curriculum. It will also enable them to become the better Indian medical graduate.